Welcome back everybody, David here again with Med School Bootcamp. So in this next chapter, we are now going to move on to a topic called urinary incontinence. And there's a few key types I want you to know about here. But first we're going to start talking about micturition overview. So that is the physiology of excreting urine from the body, the bladder contraction. Then we're going to talk about the three highest yield ones that I want you to know for test day, including overflow incontinence, stress incontinence, and urge incontinence. So if you all are ready, then off we go. So first I just want to do a general overview of the basic anatomy we need to know when we talk about our bladder physiology. So the key anatomic structures include the apex, which is kind of the uppermost portion of the bladder itself, the body, which is the muscular cavity located between the apex and the fundus, which is our posterior portion of the bladder. But the two key ones include the bladder neck, which is what actually joins the urethra to the bladder itself, kind of this area, and the trigone, which is this kind of triangular area in the bladder, which has the two urethral openings. That's where the ureters implant in the back of the bladder, going down towards the internal urethral sphincter. So you're supposed to get kind of a triangle appearance right here. And recall that the ureters actually come down and they implant behind the bladder, so you can't actually see them in this image. Next, I want to talk about some key receptors and muscles, because if we understand what muscles play a role in bladder micturition and we understand what receptors are associated with those various muscles, we can start to work backwards and think about our pharmacology in terms of how would stimulating or inhibiting these various receptors affect the patient's physiology. So recall, the first thing is that we have a large muscle called the detrusor muscle that's actually surrounding the bladder. And remember, a key point about muscles is that muscles can either contract or relax. So when we're wanting to expel our urine, we're going to see contraction of this muscle, versus if we're holding our bladder or we don't want to see expulsion of the urine at this time, we will see relaxation of the bladder. The control of the detrusor muscle involves a couple different key nerves, one of which is the pelvic nerve. This is a parasympathetic nervous system nerve that acts at the M3 receptor. And because we are dealing with the parasympathetic nervous system here, we are dealing with acetylcholine. So this nerve is going to transmit via acetylcholine signaling modalities. Next, we're going to look at another very important nerve, which is the hypogastric nerve. Notice this is part of the sympathetic nervous system. This is going to stimulate beta-3 receptors by way of norepinephrine. So you can see here we're actually stimulating beta-3 receptors. We'll talk more about what those do in a moment. Then we're going to look at some other key important muscles, one of which is the external urethral sphincter. This is under voluntary control. And then we have the internal urethral sphincter, which is under involuntary control. So voluntary control versus involuntary control. This is very important as well. These have two different nerves that are innervating them. For the external urethral sphincter, it's innervated by the pudendal nerve, which is under somatic control, releasing acetylcholine to nicotinic receptors. So we would see this acting more at the external urethral sphincter, and I'll put an N here for the nicotinic receptor. And then we are also dealing with the hypogastric nerve again. However, this time we're actually innervating the internal urethral sphincter. And so although we'll still use norepinephrine for our signaling molecule, we're actually going at a different receptor, which is the alpha-1 receptor. And so our hypogastric nerve up here can actually also go down to the internal urethral sphincter to innervate alpha-1 receptors. So those are really the key points that I want you to understand for this overview of micturition physiology, because we have essentially a few key muscles, a few key nerves, and a few key receptors. And if we can keep these in mind going forward, this really helps us understand the normal physiology for a patient. And if we understand our normal physiology, we can think backwards and say, okay, what happens if I block this step? How is this going to be useful? Can this be used for a treatment who might have a pathology where they have an error in this process where it's not working normally? And the answer is yes. A key point I also want to mention here is notice that when we talk about our parasympathetic nervous system, we're typically talking about the release of acetylcholine, versus our sympathetic nervous system, or our SNS, can release a variety of different things, including epinephrine, norepinephrine, as we see here, or even things like dopamine. So this is really helpful to keep in mind. It's also helpful to keep in mind what kind of system would we expect to see when we're actually trying to urinate or go through the micturition physiology versus what would we expect to see active at rest. And the way I remember this is I associate the S in sympathetic nervous system with the S in storage. And I remember that the S in sympathetic nervous system and the S in storage means that the activation of the sympathetic nervous system is typically acting to store the urine or keep the bladder relaxed. That means the opposite is true for the parasympathetic nervous system, and that when our bladder is allowed to relax and parasympathetic activation takes over, that is when we actually excrete urine from the body. We get contraction of the detrusor muscle, opening of our sphincters, and urine is allowed to leave. So remember the S in SNS, or sympathetic nervous system, for storage of urine, and this should help you keep those straight. Now, you might be wondering, how does the body manage all of this? And the key is that there's two actual things at play here. One is the nervous systems, right? We get stimulation from the nerves at the bladder, but we also have a higher level processing in our brain at the level of the pons, which we call the micturition reflex. this reflex is really what helps us establish, okay, we sense the sensation to go to the restroom. We're getting stretching from our bladder or detrusor muscle, and we want to contract and relieve the urine. But if we're not in the right place and it's not the right time, we need a way to balance this and say, no, not yet. It's not the right place for this. And that is the micturition reflex. So when we think about the micturition reflex, we're thinking about three primary things. So typically we're saying that we would have first an increase in urine that has the bladder stretching. We sense this. We're going to sense this in our sacral spinal nerves specifically, typically along the lines of S2, S3, and S4. And then our parasympathetic nervous system should contract our detrusor muscle and relax our sphincter to go to the restroom. However, because we have something in the brain called the pontine micturition center, it can actually override this reflex. It can actually inhibit this from occurring. And this is why we don't typically go to the bathroom anytime our bladder feels like it. We're actually able to wait to go to the appropriate place because we have this higher level processing that essentially can override the micturition reflex. So just to summarize up to this point, when we think about our overview of micturition physiology, we think about a combination of muscles and nerves that are helping sense and control this process. The actual process involves filling of the bladder, so urine comes down into the bladder, fills it up. We'll then get a stretching sensation of the detrusor muscle, and we are going to sense this in our nervous system. This stretching of the bladder is going to activate mechanoreceptors that will be sensed in the spinal cord, indicating, hey, the bladder is full, we would like to excrete. Now, because we have this higher level processing system in the pons, known as the pontine micturition center, we can verify, yes, it's appropriate to do so. And if it is, the PMC will actually allow stimulation of the parasympathetic nerves. This was going to cause detrusor contraction and opening of the sphincters to let urine out of the body. However, if it's not an opportune time or it's not feasible, the higher level processing systems will say, hold on, let's wait, and it will not lead to stimulation of the parasympathetic nervous system. And if we don't stimulate the system, we're not going to get detrusor contraction, we're not going to get relaxation of our sphincters, and we'll be able to hold our urine until a more opportune time. So this is very important. This is involuntary control, but a continual conversation between the brain and the spinal cord nerves to say how much should we be stimulating the sympathetic versus parasympathetic nervous system. Because we know, for simplicity's sake, they essentially do the opposite. The parasympathetic nervous system allows us to go, it contracts the bladder muscles, versus the sympathetic nervous system is more of our storage, and it's going to cause continued relaxation of those muscles. So next I want to dive into some pharmacology here. So the first one I want to talk about here is our alpha-1 blocker. And the classic one that they like to ask about is tamsulosin. Tamsulosin is an alpha-1 blocker that leads to relaxation of smooth muscle at the bladder neck and the prostate. So that is to say that this medication will actually inhibit the activation of this receptor. And recall, the alpha-1 receptors are typically involved in constriction, right? They constrict the vasculature, they can constrict things around the bladder. And so if we block this, we are essentially doing the opposite. We're going to see relaxation of the smooth muscle around the bladder, specifically the bladder neck and the prostate. This is really helpful for a very commonly tested condition called BPH. This is most often seen in elderly men. So a classic vignette is going to talk about a 68-year-old man who is presenting with urinary hesitancy, urinary frequency, and a difficulty actually starting their urinary stream, and this is due to an obstruction. So essentially what happens is the prostate enlarges and creates kind of an obstruction around the urethra. This is causing the contraction. So giving a medication that helps relax that area is going to help offset their symptoms. Another important medication they like you to know about includes muscarinic agonists. Most commonly tested one is going to be bethanechol, and this is going to deal with M3 receptor stimulation, ultimately resulting in contraction of the detrusor muscle. So remember, if we stimulate the M3 receptor, we're going to get contraction of the bladder. So what kind of things might this be useful for? That's right. Anything that causes urinary retention, right? If we're getting urinary retention, we either have a couple things going on, one of which being detrusor underactivity, and that the detrusor muscle is not contracting. So we can give a medication to help with that process. We can help stimulate this muscle to contract more. And we want to contrast this with another medication that essentially does the opposite, and that is our muscarinic antagonist. So in our muscarinic antagonist, we're going to see relaxation of the detrusor muscle, similarly at the M3 receptor. So now if you draw your attention up to this part of the diagram again, we're going to see inhibition of this M3 receptor. Contrast this with our muscarinic agonist. We saw stimulation, right, or a plus sign in green. Or in this muscarinic antagonist, we are seeing inhibition or a red negative sign. And likewise, can you think about any reason why we might want to give somebody this type of medication? That's right. If they have something that's causing overactivation of the detrusor muscle, so these patients, and we're going to talk much more about a few different causes in upcoming videos, but they are essentially experiencing micturition at inopportune times. Their bladder is contracting out of control, or they're not able to control it. And so we want to give them a medication that actually settles down the muscle, settles down the bladder, and we can do that by giving a muscarinic antagonist. And finally, the last key one we're going to talk about here are some pathomimetics, and these are going to have a slightly different mechanism in that they activate beta-3 receptors, and this is going to lead to, again, relaxation of the detrusor muscle. Ultimately, this results in an increased bladder capacity. So what kind of patients would benefit from this again? That's right, patients who are experiencing urinary incontinence, specifically urgency incontinence. In urgency incontinence, you essentially have a hyperactive detrusor muscle. It's contracting, 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 even when you don't want it to, even when it's not a good time to go to the bathroom. And so giving a medication that gets it to stop contracting so much and actually relaxes a little bit allows it to fill up and ultimately improves the patient's symptoms. So just to summarize here, we have 4 key pharmacologic principles I want you to remember from this video. One is that we have alpha-1 blockers. If we remember what the alpha-1 receptor does, which is a lot of constriction in our body, we can think about an alpha-1 blocker having the opposite effect. This can relax smooth muscle. We most commonly see this in a patient with BPH, and it's typically going to act around the prostate or bladder neck. Then we have our muscarinic agonist and our muscarinic antagonist doing the opposite things. One is going to cause contraction of the detrusor muscle, and the other causes relaxation of the detrusor muscle. Good thing to know is that these both work at the M3 receptor, M for muscarinic. Then we also have our sympathomimetics, our final one, which also relaxes the detrusor muscle, although a different mechanism. Now we're talking about stimulation of the beta-3 receptor. And finally, I want to wrap up this video with some key associations. One of them is that anyone that has problems in their micturition or has some sort of urinary incontinence is going to be at an increased risk of UTIs. This is most common in urinary incontinence mechanisms that actually cause retention of urine in the bladder. And could you think about why this might be? That's right. Because if we think about typical physiology, let's just say that this is our urethra, it's reasonable to think that bacteria can essentially get in through the urethra from the outside world. However, in a normal, healthy individual, we are constantly flushing out these bacteria. We're releasing urine from the bladder, and this is essentially pushing them back out of the body. However, if we have problems with this, right, or if we have things that cause urinary retention or various types of urinary incontinence, we're not getting this process to work as regularly. And if we don't, this can allow bacteria to actually work its way up the urethra into our urinary system, including the bladder, the ureters, and potentially even the kidneys. And so this is why these types of patients are going to have an increased risk of UTIs. Additionally, we also see an increased risk of micturition problems with increasing age. This is pretty commonly known or expected. Typically, as we age, our tissues, our nerves, everything kind of slows down a little bit. They might atrophy. We don't get as good of a response to our normal physiologic processes. And because of this, patients at an increased age are at an increased risk of actually experiencing different types of urinary incontinence. It's also important to know that this is more common in women than men. And it's a good idea to have kind of a rough estimate of what types of conditions and pathologies affect women more than men, just like it's important to know what kind of age ranges we're talking about. When they ask you board-style questions, they're going to be typically talking about classic presentations. Certainly, these presentations can occur in a variety of different patients from different places of different ages. However, classic presentations are important to be mindful of. So to quickly summarize this video, we talked about the micturition overview, right? Micturition is the process of actually excreting urine from the body. We have key muscles, key nerves, key receptors. That includes the detrusor, external urethral sphincter, and internal urethral sphincter, which act at 4 key receptors, including the M3 receptor, the beta-3 receptor, the nicotinic receptor, and the alpha-1 receptor. It's also important to know that parasympathetic nervous system is actually the system that helps us with excreting urine from the body, and our sympathetic nervous system, our memory aid is that the S in S stands for storage. So we can help remember that activation of this system actually decreases our likelihood of going to the bathroom at that time. We want to know these receptors and these muscles because we want to be able to work backwards and say, okay, well, what happens if we block these receptors, or what happens if we stimulate them? Remember, classic alpha-1 receptor includes tamsulosin, most commonly for BPH. It's going to inhibit the alpha-1 receptors, leading to relaxation of the areas around the bladder. We also have our muscarinic stimulators and inhibitors. These include things like our muscarinic agonist and our muscarinic antagonist. Remember, these act at the M3 receptor, M being for muscarinic. We have to remember that stimulating this receptor is going to lead to an increased contractility of the detrusor muscle, and thus inhibiting or doing the opposite is going to lead to increased relaxation, or the opposite effect in the detrusor muscle. And finally, our sympathomimetics are going to also relax our detrusor muscle, however through a different mechanism, including beta-3 stimulation. Key associations to take away from here: people that have problems with the system are going to have an increased risk of UTIs because of this mechanism right here. Bacteria has an easier time getting up through the urethra. This is what leads to UTIs. Additionally, it's also associated with increased frequency in age as well as in women.